Good evening, everyone. On behalf of Maharashtra Academy of Pediatrics as well as Catchet Pharma, a very warm welcome to all the respected seniors and colleagues for joining us today's panel discussion. Friends, change of season is nature's way of giving us a break from the monotony of one weather. This season, monsoon is playing hide and seek with us. As we think of preparing for the next season, rains keep coming, ringing our doorbells. Wet clothes, humming mosquitoes, humid atmosphere are sights to behold. Change in weather definitely uplifts one mood, but certainly at one point becomes harsh for our children to deal with cough and cold and other seasonal illness. Well, it's true. This time, our OPDs are flooded with children coming with cough as a major complaint. But it's also true, children with repetitive or persistent cough are difficult to handle and manage both for parents as well as us. Today, MahaIP has arranged a special panel discussion with stars in this field. But first, I welcome our MahaIP President, Dr. Hemant Gangolia, sir, to give his blessings. Over to you, sir.
Thank you, Dr. Neha. Good evening and warm welcome to this webinar hosted by Academy of Pediatrics. And we are extremely fortunate to have the excellent guest speakers in form of Dr. Jagdish Dekne sir, Dr. Subbu sir, Dr. Viswal sir, as well as Dr. Jayan Joshi. And we are also extremely fortunate to have guests for today's episode, Dr. Basavaraja sir, Honorary Secretary General for last 2 years, and at present President of Bangalore IIP branch, and as well as probably in absentia, Dr. Piali Madam was going to join. So hope so she joins. So welcome to this dais, and on behalf of Maha Academy of Pediatrics, we are extremely thankful to Catchet Pharma to support this event, to give this academic support to for this webinar. This is the sixth time they are supporting us, so we are extremely thankful to Catchet Pharma. Well, today's topic is cough, and as everybody knows, cough is almost 70 to 80% of the patient we see in the OPD and today, and in these days is really flooded. Most of the pediatricians are having centuries in their OPDs, seeing the patients in a bulk, and so cough is a symptoms which we have to tackle. And though the tagline which was said, "Love and cough cannot be hidden," but sometimes love gets hidden, but cough never gets hidden. So with that note, I welcome everybody and wish all the attendees of this webinar a happy learning, and let's move ahead. And thank you, madam.
Thank you so much, sir. I would request Dr. Basavaraj, sir, to kindly unmute and give his blessings, sir.
Thank you, Dr. Neha Singh, Madam. Respected President of Maha IAP, Dr. Hemant Gangolia, sir, my good friend, and Dr. Amol Pawar, our Secretary of Maha IAP. Jodi number one has really taken the academics to the far excellence, and most of the people across the country are looking at Maha IAP program, which is a more practical and what is required in day-to-day practice. And today's discussion, I am sure, with the little master, our Dr. Subramanya, is a well-known, internationally renowned pulmonologist, and is done an NRC chapter, neonatal national respiratory chapter, in a very big way activation across the country. So it is going to be moderated by that, equally assisted by our great pulmonologist from Pune, Dr. Jagdish Dekne sir, Sabar Ranjan Biswal sir, of course, the others in the thing who are Jayan Joshi, our Vice President of National Respiratory Chapter is here. So I'm sure this is going to be giving a lot of practical tips to it. Thanks to the Maha AP, thanks to Neha Madam, and I missed one of the program. I'm extremely sorry for that. That day I was in a network was poor. Thank you, Maha AP, for inviting me to be here. Thank you so much.
Thank you so much, sir, for your valuable time and your presence. Thank you so much, sir. For the panel discussion, I would request practice, we have dignitaries with us, Dr. Jayan Joshi sir, Dr. N.K. Subramania sir, and Dr. Sibaranjan Biswas sir.
Yes.
Jayan Joshi sir is a Central IIP EB member, Maharashtra, past, and he is vice chair. He was vice president, chairperson IIP ID chapter 2020-21. He was vice president IIP respiratory chapter 2021-22. Council member Maha IIP 2015 to 2019. He was president IIP Pune branch 2016. He is national trainer for various IIP modules. He is member IIP guidelines on pediatric cough therapy, and he has 3 publications and 2 book contributions. At present, sir is senior consultant pediatrician at Dinanath Mangeshkar Pune and Shayadri Specialty Hospital Pune. He has special interest in infectious diseases, pulmonology, vaccinology, and neonatology. We also have with us he is Professor of Pediatrics, Chairperson IIP National Respiratory Chapter, past Secretary National Respiratory Chapter till 2020, various posts in IIP as faculty in modules, CME and conferences, oration, books and publication. His special interest is pulmonology. We have with us Professor Dr. Sivaranjan Biswas, sir. Sir is professor in pediatrics at KIMS KIT University, Bhubaneswar. He was since 2005, EB member Orissa IIP 2008, 9 and 2006. Organizing Chair Secretary State Pedicon 2016, EB member East Zone IIP 2021-22. Secretary IIP Orissa 2021-22. More than 20 publications in national and international journals. His area of interest is pediatric cardiology and infections. We also have with us Dr. Jagdish Dhukne sir. He is consulting pediatrician from Pune, past president IIP 2010, past president IIP Pune branch 2008-9, director of Unique Hospital of Children Pune. He is master trainer of asthma training module of IIP and master trainer in pediatric infectious diseases of Karthik Group of Hospitals, Pune. As moderator, now I hand over to Dr. Jagdish sir for the further. Over to you, sir.
Can you hear me, Neha and all others?
Yes, sir.
Yes.
And I'm audible and I'm visible.
Yes, sir.
So good evening, everybody. And then without wasting much of time, I think I get back to the, the presentation and discussion on cough. Now, remember, it is one of the most distressing symptoms that you are coming across in the last few, I think, months. And all of us are really bugged with the amount of cough children are having in our clinics. And to add to everything is that most of the children keep on, not getting all right with whatever we are giving. And that's why we want to really find out what all the pediatricians over here are doing and what we must do. So pediatric cough diagnosis and management, this is on the OPD basis for a practicing pediatrician. All of us will agree that it is one of the commonest symptoms. It is isolated or comes with fever and breathlessness, recurrent in nature. Very often the child comes back after 8 to 10 days again with the similar symptoms. And the possible diagnosis can be just benign viral infection. And parents keep on saying, kitne time viral ho jayega? And it could be also be an underlying infection, which can be as serious as a TB. So it's a real test of our clinical acumen. Many are non-infective. We realize that none of the antibiotics really work, and all of us are giving antibiotics for some reason or the other. X-ray chest, hemogram really do not really work because most of the routine investigations are normal in patients with cough. It is distressing not only to the child, but more to the parents, and even all of us are distressed with the cough they come across to us. And does really any cough remedy work? Bronchodilators, antihistamine, mucolytics, cough suppressants, expectorants, irrational combinations, do they really work? And in fact, most of us do not really know what are the ingredients of the cough syrups we regularly prescribe. And what is the approach? We are going to discuss this. It's a challenge. Detailed history, all of us know, is very important. Chronology of symptoms is important. A clinical examination very important. And a detailed history is what probably gives you the diagnosis and the rational management. All of us know on this slide, and see, significant cough is a mark of the airway disease. And we'll just go through the respiratory microanatomy. All of us know larger airways are involved when the high intensity cough is there. Smaller airways, cough is of a lower intensity. In pneumonia, please remember, cough is not a very prominent symptom and comes up later in the disease. Fever is a major symptom in pneumonia. Breathlessness is a major symptom in acute bronchiolitis. And cough in a child with acute bronchiolitis signifies airway involvement. Yes, normal children do cough 1 to 34 times, and after an LRT, a viral, which is so common, please remember, normal children can cough up to 14 to 21 days. All of us know that cough receptors are in the airways, and we know that cough signifying significant airway disease. If cough is not significant, we are dealing with a parenchymal, pleural, or interstitial lung disease, and it can also occur secondary to GERD. Dry cough is airway disease. Wet cough, when the cough is more than tachypnea, lower larger airways, and lower small airways are involvement tachypnea more than the wet cough. Now, with this small introduction of the, how we go about with a child with cough, is Jayant there? Jayant?
Yes, sir.
Yeah. So,
Yes.
Jayant, now see, what is commonest with all of us is in any infant who is less than 6 months of age presents with cough. And when a child was 6 months come, we are all really, really worried, because this is a patient who has a lot of problem and parents are naturally worried. Can you guide all of us as to how do you approach a child with any, or an infant who is less than 6 months be present with predominant cough?
Yeah. So thank you very much. Good evening, everyone. Greetings from Pune, and nice to see Dr. Subramanya, my dear friend. Welcome, Dr. Biswal, sir. Dr. Dekade, sir, as usual, thank you very much for the opportunity. And as regards this child who comes less than 6 months of age present with cough, now it is now generally expected that a baby who is less than 6 months of age would be probably breastfed or exclusively breastfed. So first and foremost thing, when the child's parents come to us with a complaint of cough, we would like to ascertain whether this cough is coming in the way of baby's feeding, because breastfeeding is an activity where where there is a requirement that the nose should be open, the baby should have a normal breathing rate, and the baby should have normal swallowing mechanism. So even if the parents complain that the baby is having cough, if the baby is able to feed properly and on the growth chart the baby is showing good growth, I personally would not get worried too much about the coughing. However, for a very small baby, when the baby is coughing and if the cough persists beyond a reasonable time, I would make two inquiries. I would ask if there is any similar cough in the contacts, particularly the elder ones who have any cough which is lasting for more than 3 weeks. And number two, I would ask if the baby has had any fever in the past or any close relative who has got any fever recently. Also, I would like to ask if the cough is so severe that the baby is literally vomiting after every coughing, or if the baby is very small, if the baby has had an apneic spell. So this probably would point towards the possibility of pertussis. As we all know, in our country, the incidence of pertussis is on the higher side. The immunization may not be complete. So in such a situation, in a well-to-do family, when a child is thriving well, when the baby is feeding properly, I would not worry about the cough much. I would reassure the parents. On examination, I would see if the baby is having a normal respiratory rate, if the baby is having tachypnea, if the baby is having retractions, if the baby is having nasal flaring, then these are the signs which are evident of a respiratory distress. I would also ask about the cough which has been there since birth or it has happened over a short period of time. So this will help me guide whether I'm dealing with some kind of a congenital abnormality, in which case the cough probably would have an origin because of the anatomical abnormality. And if it is happening recently, not affecting the day-to-day activity or the feeding pattern, it probably would be an incidental finding, as would happen in any other viral infections. So this is in short, I would approach the case of cough. Now, if generally, as sir rightly said in the beginning, there is no cough syrup which is 100% effective, and in less than 6 months, it is generally recommended that you should not use any cough syrup because they would have more of a side effect profile than to give benefits to the child. So if at all, if the child is having a lot of distress, I would prefer to give an inhalational therapy in such a case rather than giving an oral cough syrup formulation. I would also make sure that the baby has an open nose, because nose block is something which is very, very common. And because of nose block, the child could have a coughing episode. This is what I would approach for a baby who is less than 6 months of age. Thank
Dr.
you.
Ranjan, would you give an antibiotic in this patient if the cough is more than 1 week? Would you give an antibiotic, and which antibiotic would you give? And what would you give as a inhalation therapy? Would you give a meter-dose inhaler and a spacer, or nebulize this child? Because the child may be a little tachypneic. Okay? So what would you do? Yes, Dr. Ranjan?
Thank you, sir. Good evening, all. I am first of all thankful to the MahaIP for giving this opportunity. So, first of all, I have to find out what is the underlying, whether the fever is associated with this cough or only cough is there. The fever is associated with cough, we may think of infectious etiology, and usually in the earlier age, the virality is more common than the bacterial cause. And after that, I have to find out what is the duration of cough, as well as whether we have to examining this local examination of the chest. We have to find out any local signs, whether it is favoring towards the pneumonia or like that, and there is presence of crepitation and fever. If it is cough is after the fever for some days, we may think on the line of pneumonia, and we can give the antibiotic as per as appropriate, like amoxicillin, chloroquine acid,
Yeah,
for inhalation
Subbu,
therapy.
yeah.
For
Yeah,
inhalation therapy, basically we'll think for nose block. So we should use the normal saline in spite of giving any decongestant, which is cause rebound congestion and is not indicated in this age group. So first of all, we should to give this. We should clear the nose, as well as if required, we can give some antihistamines when the cough is irritating or your cough is severe, and we can give some antihistamines for this.
Okay. Now, Subbu, can you tell me what cough syrup will you give? Because parents will keep on asking you. You can't say that no, the cough is there for 8 days, it is increasing. So what medicines will you give? You have to give an antibiotic, you have to give some cough syrups to make them happy, or at least they can be just coming to talk with you rather. They should be able to you should be able to use some medicines, or no, or not at all. Or you just like to counsel them. What would you do in your clinic, Subbu?
This is a very, very tricky situation. At least for me, I will classify that below 6 months into real newborn, and the one which is little older than a newborn, because it is dangerous to give any oral medications in newborns. That much is for sure.
But we all give, isn't it? All of us say so, but we all
something which
give.
I would strongly discourage, because cough is never an airway disease and it should be treated almost like a systemic disease.
Okay.
There may or may not be respiratory distress, and it may appear little later or sometimes. So you will never know. So that is one thing that I would like to tell you. Take an exception of for example, chlamydial infection sometimes can present with that staphylococcus in very young age. That sequential cough, if you find, maybe a macrolide will work, but it is again, I will cross my, I'll keep my fingers crossed unless you are very shrewd and make a final diagnosis. Azithromycin should not be misused. That is one part. The second part is regarding the nasal block and clearing. That is something which is really going to help in this cough. The mother may refer to a cough, but it may be the cold and nose block, but her words or her version may be more cough. Please understand, this is like in OPD practice, sardi kokla, they may actually mean a nose block and a cold than cough, which is dominant. And I think simple paracetamol drops plus nasal saline drops and nasal clearing and suctioning, sometimes using a bulb, would give a lot of relief. The next thing I would like to find out is, are the symptoms of the cough acute, recurrent, persistent? How is the child? And whether the child is thriving well, if it is persistent, and are there coexisting symptoms? Is cough an isolated symptom or part of the symptoms of other coexisting with other symptoms, especially noisy breathing? This is something which we need to ask. Yes. Lastly, I would say, please ask about aerodigestive symptoms. Association of vomiting, reflux, and all these things are very important, because aspirations and post aspirations, they are quite common. Post infectious is again common. Why I told you is because you should not treat the cough, you should treat the cause of the cough. So that's
Got
the
it.
point. Any self-limiting disease discourage from using any of the cough medications. And if at all you want to use any safe drug below 6 months of age, I would say only salbutamol.
Only
And if
salve.
at all you want to give salbutamol, it should be preferably aerosol, that is nebulization. I have not
But
used.
most pediatricians, Subbu, feel that no, the beta 2 receptors are not developed. So below 6 months of age, do you use oral salbutamol or inhaled salbutamol?
No, I have not used oral salbutamol below 6 months
Very
of
good,
age.
very good.
And
And do you
I'm very
combine?
bold,
Yes,
but I could be wrong.
yes, yes, yes,
But
yes.
the thing is that I have nebulized. But let me also confess in telling you that below 6 months of age, I have not used MDI with spacer.
Okay,
Because
great.
sometimes, first of all, I do not know whether the salbutamol works, and I don't want to have confusion of the device. I think it would be pretty simple. 6 months and below, we should be using nebulizers because that's fair. But only thing is there should be hygienic, good nebulization practices. And remember,
Okay,
it's not important whether you use salbutamol, but it is very important after using salbutamol whether that particular cough responded. In
that's
case if it responded, continue. If it doesn't respond, don't go on giving every 4th hourly or 6th hourly.
correct.
That I
And
would
do you combine salbutamol with inhaled steroid also? Would you like to give a combination salbutamol plus beclomethasone as nebulization or only salbutamol?
at this stage in a breastfed child, absolutely no. And in a child with no risk factors for allergy and asthma or atopy, absolutely no. Steroids
No.
do work only when there is some kind of eosinophilic inflammation, and very, very rare to diagnose asthma below 6 months of age or asthma mimics below 6 months of age. I mean to say the phenotypes of asthma which may over time becoming asthma. So these two are very rare. Maximum that we see is post bronchiolitis, post-infectious cough in these children, which would just require reassurance. Please ask the
I
mother how
think
many
what
times the child coughs, because if it is 3 or 4
yeah,
times, it just requires reassurance.
reassurance. But if
And
it is
one
more,
thing,
you can only use
that is sorry for this, please do not use honey.
yes, honey, yes, correct. Okay, so I think we have a discussion on that. This is a very tricky situation in real practice, and most of the drugs are not recommended, like combination of dextromethorphan and chlorpheniramine. Please remember, these are very dangerous drugs, and what we need to do is a watchful waiting, reassurance, good counseling, and just pray that the cough declines over a period of time. Now, Dr. Ranjan, see, we use a lot of antibiotics in the child who comes in the cough in our OPD. Now, I want you to give us a clear-cut instructions on which antibiotics for which infection, how do you diagnose it, and which age you use it. For example, we use azithromycin in babies with chlamydia, prevalent staccato type of cough in children below 6 months of age. What are the other antibiotics you would normally use in your own OPD when a patient comes with cough? The cough is there for more than 8 to 10 days. And there is a little bit of increase in polymorphs and a few shadows in the X-ray that you have taken. Okay. And the radiologist always says, please correlate clinically. Okay. So will you give an antibiotic first of all? And which antibiotic will you give? Now, this is a question that most pediatricians will ask themselves, for which there are no definite answers. So can you give us some definite answers? Yes, Dr. Ranjan, please.
Yeah. Usually less than 6 months, the viral infection is more common than the bacterial infections. So that is more. So very rarely, if it occurs, the atypical organisms are more common. And as sir told, whether chlamydia, you can give azithromycin. For gram-positive infections, we have to think for amoxicillin.
Amoxicillin. Okay, that's your drug of choice. Okay. And what about the role of azithromycin in children older than 5-6 years of age where you're suspecting mycoplasma? Do you give azithromycin for older children more than 5-6 years of age? Would you use azithromycin? That is what most pediatricians do. In children below above 6-7 years of age, school-going children coming with cough, which is persistent for a long time. The child is otherwise very well preserved, doesn't look toxic. Would you give azithromycin?
Usually,
Yes,
in this condition, we have to give the macrolides, either azithromycin or clarithromycin. You are using this.
Okay. Any input from you, Subbu and Jayant?
Let
Hello?
Jayant you
So
speak.
I would, yeah. So I agree with Dr. Biswal that generally the antibiotics would not be required below 6 months because most of the times it is going to be a viral etiology. In a rare scenario, as Dr. Subramania said, that if it is a chlamydia, you could think of azithromycin. But first and foremost thing, take home message is that azithromycin to be avoided as much as possible. Number one. Number two is that whenever you use any antibiotic, you must have, remember, suppose you are talking about a situation where you are suspecting mycoplasma. We are discussing about cough management. Your antibiotic giving in that particular situation is not going to affect the cough of the child. So whether or not macrolides are going to be effective in controlling the disease symptoms or cough is a questionable issue. You can use macrolide, you can use azithromycin for macrolide in an older child, that is fine. But if a discussion is focused around management of cough, I think that is going to contribute very little. By giving an antibiotic, you are not going to change the course of cough. On the contrary,
But
if you take any viral infection, or for that matter, any bacterial infection, during the course of recovery from that infection, you would probably expect the cough to increase slightly. Even a child who is recovering from a lower respiratory infection would continue to have some kind of a cough for about 2 to 3 weeks. So if you are giving an antibiotic for treating the cause, meaning thereby after confirming that there is an infection, and then for that reason you are giving an antibiotic, you are justified. But if you are giving an
yes,
antibiotic for the control of cough, it has no
no,
meaning.
no, but the underlying cough has to be treated well. No? The infection has to be treated, no, Jayan?
I
Can I?
Because
understand, but
ultimately
then
it's the infection that is the cause of cough, right? Yes, Subbu, would you like to add something to
yeah.
this discussion?
Yeah, sorry for the 30 seconds or so. I lost the connect. I couldn't hear Jayan's comments, but let
Okay.
me tell you a few things. If the antibiotic is not required in first 2 or 3 days, then it may not be required in the first week and second week of cough, because that means that for example, fever, respiratory distress, evidence of infection was not there, and just the cough continues only and rest. Otherwise, the child is normal. What I meant was the distress has gone, the feeding is better, fever has resolved, but cough persists. This is when I will not give antibiotics just for the reason of persistence of cough. Let me make it very clear.
Okay.
The
So
point number
antibiotics
two
have,
is the point number two is if the child has got dry cough or wet cough. I think this is a very important point. If the child has a dry cough, again you can avoid antibiotics, but because it is more an irritation. And if the child has a wet cough, and how can I make it below 6 months of age or probably infancy, is put your hand on the chest of the child and you can see, you can even palpate the secretions or the wet chest. Many a times it is possible, especially if you can make the child cough, and even you can hear with your stethoscope wet cough. And I think any wet cough of more than 4 weeks or 2 weeks should not be ignored, because that's something important, because that may speak of some future disease. And that is when wet cough more than 2 to 3 weeks of duration would definitely qualify for an antibiotic. Please, in this
I think
case,
that is a very excellent observation or a
because
point that I
in
think
that case,
really
you need to resolve the infection. Persistence of cough is
yeah,
not the reason. The nature of the cough is the reason. The
yes.
probable
So it's the
disease
wet cough that requires an antibiotic, right? Yeah.
Sir,
and dry
if I may just
that is, let me complete. If it is a dry cough, please find out if there is an environmental offender in the family, like a smoker or agarbattis, etc. Not necessarily an asthma. There could be an irritant in the house, or this dopam and all they will do for these children after bath and all. They will give that battis and all that. All these offenders have to be taken. Okay, back to you.
sir, just
Okay.
can I add?
Yes, yes, Jan. Go ahead.
Like how Dr. Subramania mentioned about any wet cough in a small child beyond a period time requires an antibiotic course. Similarly, for a child who is slightly older, if a cough is persistent and wet cough, one would think a possibility of persistent bacterial bronchitis. And in such a case,
Yes.
probably you would be justified in giving a course of amoxiclav, that is the most preferred
I
antibiotic
think
there.
that's a very good point you have brought to Jan. That's very, very
Yeah.
important. So persistent bacterial bronchitis has been increasingly recognized as a cause of persistent wet cough. The word wet is very, very important.
I
So
think
Jan, now
Jagdish,
there's a lot
Jagdish,
of yeah,
Jagdish, can
yeah.
I just
Yes,
add
yes.
one
Tell
more point?
me. Yes, yes,
If you, with your
yes, yes.
permission, suppose
Yes, of course.
I will just bring in that RNTCP or NTP concept here. Any cough of
Yeah.
more than 2 weeks, if it is with fever or wet cough, would also go for a
Hmm.
course of amoxicillin for a week plus to rule
Correct.
out and then
Okay.
consider tuberculosis. Therefore, we are all in
Yes,
the
yes.
same algorithm. So we should
Yes,
understand
yes,
that
absolutely.
first 2 weeks, no. Second week, if you take a community pediatrician approach, give amoxicillin, tuberculosis do not respond, and therefore it amalgamates with NTP algorithm. So therefore,
Yes.
consider antibiotics, especially wet cough, or as a part of NTEP in the second week onwards.
Yes, I think that's a very important message Subbu has given to all of us. And now, Jayan, nowadays, there is a lot of flu going on, and swine flu, and all this. And when do you exactly use oseltamivir in your practice today? Patients come to us, high fever, cold and cough, X-ray shows some infiltrates bilateral, counts are normal, then you feel there is an LRT, and you're always worried. Should we give oseltamivir in these patients when they're coughing very badly? Would you give it to all of them? And what is the exact role of oseltamivir? When started it as the maximum benefit? Can you just enlighten us on what do you feel, Ajay, we should do?
Yeah. So I think if you are in the middle of a flu season, if you have an acute respiratory viral infection with plus or minus breathlessness, a lot of coughing, and if there are other children in the family or in the surrounding who are having similar complaints, so a situation which is more suggestive of an influenza-like illness. In case if it's a high epidemic season, if a child is showing signs of distress or showing signs of a lot of vomiting, high-grade fever, then one can use oseltamivir as a prophylactic antiviral if it is most effective given in the first 72 hours of the illness. But the fact of the matter is that more often than not, children are brought to us after the second day of fever. Now, after that, also, there is some role, even if you are in the epidemic of an influenza, it is fully justified that you still should go ahead and give an oseltamivir if you are dealing with a scenario where there is a possible influenza-like illness, and if there is a possible history of a child who has had a past history of say a reactive cough, or who has had a hospitalization for a respiratory tract, or who has got other immunocompromised situations like a malnutrition, not doing well, or if their child has had a recent history of measles or some kind of an illness, then these are the situations, these are high risk children, wherein probably you would definitely earmark them. And in a dense population, in an epidemic season, you would use oseltamivir upfront, most effective in the first 72 hours of the illness.
Yes, Jayan, very nicely summarized. Any additions, any inputs from Subbu or Ranjan?
No, there is nothing that we can
Okay.
add to Jayant, and he has
Okay,
almost
okay.
completed.
Now, Ranjan, there are a lot of patients who come with recurrent cough, and many pediatricians write Montelukast. What is your take on the use of rampant use of Montelukast amongst pediatricians, given for 5, 10, 20 days? Can you just enlighten all of us and stop the irrational use of Montelukast, Ranjan? And of course, Subbu, you're going to talk on Montelukast for half a minute at least. Okay.
Okay.
First of all, we should know what is the cause of cough, whether it is recurrent or not. Second thing, we would think for the family history, if there is an atopy there or anything else there. So if you are, it is a due to hyperheredity airway or due to asthma. So sometimes Montelukast you are using for a very short period, not for long period you have to give. And that also depends upon the types of asthma. And not like acute intermittent asthma you have to give. So that's why you cannot give for a long time, because they have some adverse effect. Which is not advisable to give for a long time. And if it is already known history of family history of atopy or asthma, and the attack is more like persistent asthma is there, so sometimes it may be used for short period.
Subbu, you're going to talk a bit on Montelukast now.
Okay.
Please give us clear instructions. So, Subbu, you're an
Okay,
authority on the use of Montelukast.
Okay, let me speak from my heart than from my brain.
Yes.
Okay, that is what you want. Okay,
Yes.
when I have used Montelukast and when I have not used Montelukast, I have not used Montelukast when it is asthma. I have not used montelukast when it is not asthma. That completes all the diseases. Point number one.
That is great.
Number two is if it is asthma, you use steroids. If it is not asthma, when you don't need steroids, why do you need montelukast again? See, montelukast is required wherever steroid is indicated as an inferior alternative. Let us have this clear-cut message that if you think of using montelukast, the steroid should come ahead of prescription of montelukast for you. Then I am fine. I think I've made the message very clear.
I think so.
If it is steroid non-responsive, a small segment may be considered for montelukast, but that also forget it. Number two, regarding the prescription habit of montelukast, no co-prescription with levocetirizine. Number two, no montelukast less than 1 or 2 weeks. It makes no sense. Number three, when do you need montelukast in practice? Okay, is it an outdated drug? Answer is no. You definitely need in situations where there is concomitant allergic rhinitis and asthma. Probably this is a small segment of patients whom you may add montelukast to an inhaler. That is, for example, formoterol, budesonide going on with them just to tide over that sneezing episode of 1 or 2 weeks when you have only sneezer but not blocker, and when you don't need intranasal steroid. Am I clear? You have got a situation where you don't need intranasal steroid. You have used steroids for airways in the form of budesonide, but you need just to add on. Then you can add montelukast just to calm the storm down. Okay, but basically, why?
How long, Subbu?
Yes, why this hue and cry? This is simply because montelukast is leukotriene inhibitor. It is not receptor antagonist, and it is not a broad spectrum anti-inflammatory. It is a narrow spectrum anti-inflammatory, only acts on leukotriene receptors. Steroid is a broad spectrum anti-inflammatory. And when I use this word broad spectrum and narrow spectrum, you will definitely understand when you use a narrow spectrum antibiotic and when you use a broad spectrum antibiotic. Narrow spectrum is used when you are very specific. So you will know by practice who are the candidates for montelukast. Definitely it is not a replacement for counseling for a good steroid inhalation corticosteroid. Not in that sense. You should choose a particular child for montelukast for around 3 to 4 weeks. I have given in allergic rhinitis, sneezer with moderate to severe asthma, and that is where I have used. Otherwise, absolute no. This is a big flop movie in the recent past. No Oscar, nothing. You can forget montelukast like all the cricketers who are going to retire.
Okay, so. But I think it is rampantly used. And I think what you said is a few weeks. I think it should be used for a very long time in case you are
very long time. Few weeks. Yeah. No, I'm telling not less than. I never said.
What less than? How many weeks you said? 2 weeks.
No, not less than 2 to 4 weeks. Don't use it for 3 days. No, and secondly, where it has worked, the perception of the pediatrician is important. Where it has worked, the levocetirizine has worked, not the montelukast. No. Please remember, use levocetirizine alone, it will work.
Yes, I think the clear message is, yes, Jan, you want to say something?
Yeah. And one more thing, even though it is being used rampantly, we must be aware that it is not without side effects. It has been conclusively proved that montelukast does have some psychiatric problems, so it should not be used very commonly in even older children. It is being recommended now, but it has got a lot of side effects, and they can cause even tendencies like suicidal tendencies are well known with overdoses of montelukast. So all in all, as Dr. Subramania said, it's an inferior drug to be always used as a secondary option along with steroids, and has a very, very limited role to play, and of course has no connection of treating cough. Thank you.
Okay. So to summarize,
can I come in for only last slide?
Yes.
If there are, so suppose I have given an anti version for montelukast. If there is somebody who wants to say, let's say, okay, sir, tell me at least some pro version, soft corner. Suppose if I have to have some soft corner for montelukast, the only indication is a multi-trigger wheezer who refused to take inhalation corticosteroids.
Okay. That's right. So I would just summarize and say that montelukast is an inferior option, far inferior than inhaled corticosteroids. It's at the most an add-on drug in patients who have allergic rhinitis. when viral infections are the commonest trigger, and when patient is not taking the inhaled corticosteroid properly. And please remember, it has to be given for at least a minimum period of a few months, I would say, at 1 or 2 months at least, and not for 7, 8, 10 days. Is it okay, Subho? I think.
Yeah, okay. If you want me, want the audience to remember very correctly, the steroids, inhalation corticosteroids is like your wife who stays with you for long. Montelukast is like a glamorous girlfriend for you who can be for short, look glamorous, very expensive, can only be add-on and inferior alternative.
Yes, yes, yes. So thank you, Subbu, for that. Okay, thank you. Now, Subbu, the question is for now, you have a long innings to go now. See, how should a pediatrician not miss serious diseases underlying the cough? I think I want you to elaborate on a clinical situation when a cough is a serious, underlying serious illness. How should a pediatrician not miss?
Okay, I will tell you the markers of a serious disease in the child. Absence of cough can be a serious disease. Number one, a low intensity cough, very important. The third thing is the other symptoms are more than the cough. Then it is a serious disease. For example, fever is more, cough is less. Breathlessness is more, cough is less. I think I'm making it very clear.
Yes.
The co-symptoms are more than the cough. Then it is a serious disease. And a serious disease, don't look at the cough, look at the child. The child is sick. It is not a cough that makes a child sick. So therefore, it is the child. In acute, the child will be sick. In chronic, child will fail to thrive. Only this. This much is enough for somebody to recognize serious disease. Please look at the clubbing. And I think a pulse oximetry, looking at the clubbing and looking at the distress, removing the shirts and proper bunions and properly examining the child, not just auscultation, and proper growth chart, vital parameters of the child, presence or dominance of the co-symptoms with the cough.
Correct.
And that makes the child to have a serious disease. This is all that one has to remember. Any systemic manifestations like hepatosplenomegaly, lymphadenopathy, etc. Remember, fontanelles are normal, all these things. Please remember that it is a systemic disease and a serious disease.
Yes. So cough can be one of the manifestations of a systemic disease in which the cough may not be the main symptom with which they come to us, and the other things are very important. So the general appearance of the child and the growth chart can help the pediatrician to pick up a serious disease underlying a cough. Now, how do you manage a prolonged disturbing cough that we are seeing in the last 2 months? I'm using the word prolonged and disturbing cough, Subbu. How do you do?
Okay. Prolonged disturbing cough, not pertussis. Let me take it first.
Yes.
Let me take viral and pertussis separately. If it is a prolonged disturbing cough of viral, please remember that ask the mother to keep a cough count. She says the cough, I will tell you what happens to the cough. You will have fever, cold in the first couple of days. Cough starts in 4th and 5th day, peaks on 8th to 9th day, and then comes down by 2 weeks to 3 weeks. This one everybody should know. So therefore, it is more disturbing in end of the first week and beginning of the second week. That is when it is very tricky and tempting for a pediatrician to prescribe an antibiotic or change the cough syrup. What I have done is most of them would prescribe 60 ml or 100 ml bottles, my colleagues, and it will never be finished in 3-4 days. I will ask them to give, but less dose. See, all that I've told them that this is useless. Don't buy any other bottle. Whatever Ganga Jal you have, put 1 or 2 drops and just forget it. That is one. Second thing is, when that means it is probably at the night time, I will tell them that disease won't occur in the night. I will counsel about the disease than about the cough and explain them about self-limiting disease. See, please divert their discussion from the cough to the disease causing the cough. They say cough is getting worse and worse. Tell them that the disease is getting better and better. That is important. Ask them, do you want the cough to be treated or disease to be treated? Then they will always choose the disease. I think it is pretty simple. It's about counseling and prescriptions. I will tell you, none of the syrups help. When they did not help you in the first week, there is no reason why they should help you in the second week. Change of cough syrups, absolute no.
Okay. And how do you recognize the nature of cough? That's what I wanted to know. How do you
The
recognize it? Yeah.
nature of the cough is simple. Best thing is to make the child cough in front of you. One, but nowadays with the COVID and all, it was very difficult for me. Jagdish, I don't know how did you handle. They will hold on then cough. Then we will not know the nature of the cough. But at least I'll ask them to turn to the other side and cough. And the mothers help them. And it is also wise to keep the stethoscope on the chest while the child is coughing. Then you can recognize sometimes the wheeze. It is possible. And I think this is very, very important. Rattling or wheeze. If you get a wheeze, often it is dry. If you get that rattling secretions, often it can be wet. And I'll show you some of the coughs that you can recognize if possible. See, what comes from upper airways will be, this is called as throat clearing cough, and it is pretty normal. And this is also functional coughs that you see are all throat clearing cough. The coughs which come from the glottic, supra and subglottic areas are little violent coughs. They will make more loss, more noise, and tracheobronchial coughs are again violent. I'm not very good in mimicking cough like Parmesh, but let me try. This is tracheobronchial, which you get croupy coughs. This is like very loud coughs. But on the contrary, when you go down to smaller airways, you get a cough that is mixed with the wheeze, and I will try to show it now for you. Could you get the wheeze? I don't know whether my...
Yes.
You
Very
could get
good.
that last part of the wheeze.
Yes.
And that's very, very important for us to get that streaky wheeze along with the cough that goes down the airways. And more the streakiness, more down the airways, the cough is. I will show you medium airways and small airways cough if at all I can. This is medium. Smaller I'll go. I will try much smaller. Now we have much smaller airways. And it is possible to go down more mixed with the wheeze, more with the breathlessness is smaller the airway, and more louder and noisier the cough, the more closer you are to the larynx. So that's very, very important for you. And secondly, if the cough happens in bouts, then it's either it's pertussis or asthma. It's called pertussoid coughs. This is the way. If the cough happens in breaks, then you don't worry. Often that is not important. Breaks means this is not at all important for us. And this is very common in practice. Counseling is, if at all the child cannot cough, I will ask the mother, please show how it coughs. Often she is able to mimic the cough for us, and we'll tell that it is pretty benign. And that's, I think I have tried my best to mimic the natures of the cough.
I think excellent. You've done a great job.
I don't know how far it could reach.
No. I appreciate that. And I think it was very good, in fact. But what I do in practice, Subbu, I'll just share it with you. I ask them to get a video recording of the cough,
That is one. A second thing that is what you can do is, suppose if they can't connect to you, you show them all this cough and ask them which one is matching. They will tell, sir, oh, pehle wala, dusra wala. And sometimes see, even the mothers remember, if she forgets a video, suppose she sees an unpad gavdi, then you can show this cough. Is this like or this type? They will usually say, sir, wo jaisa tha.
No, but I've got I will get the video recording and send it to you only. That is much better.
No, when you get a video record, mother only will diagnose.
That's true. Anyway, excellent. Subbu, thank you so much for your inputs. And Jayan, do you really use steroids? And put your hand on your heart and tell me, do you use oral steroids on a patient with cough? And you have to put your hand on your heart and tell me, don't use it at all, or have you used it anytime? And when did you use it? I want a true answer from you. Okay.
Yes. I would not hide anything from you. See, I would be using steroids only in two situations. One, if I am dealing with a child who is a known asthmatic and who is on inhaler therapy, and there is a possibility that the child is in the stage of flare-up. And in such a case, probably if a child is showing signs of breathlessness, I would be justified in giving a short course of rescue steroids. Second place where I would be using steroid is in a situation when there is a lot of croup. And in such a situation, if a child has got an inspiratory stridor, probably that would be a situation where I would be using the steroid. And these are the two situations within office practice would be relevant.
Yes.
Third situation would be in very rare situation where you are dealing with situations like chronic cough. Probably there would be a justification just to rule out whether there is an allergic component. A short dose could be justified. But these are the two primary situations where an oral steroid would probably justify.
I think, Jayan, these are the only situations in which I would use steroids. I fully agree
Yes.
with Dr. Jayan. I'm sure Suban Ranjan, do you agree with what he said? I think so.
I agree, but what I wanted to caution the practitioners is don't use both steroids and antibiotics together and give compliment that whichever you want has worked. See, that is something which is wrong.
Yes.
And second thing, Jagdish, if you could permit, I'll share a personal experience.
Yes.
What happened was one of the very brittle patient did not agree for a trial of inhalation corticosteroids. I was almost sure of asthma. I wanted to give trial of ICS for 12 weeks. That mother did not agree at all. I told her, take 10 milligram of prednisolone for 2 days and come back to me. She said, sir, fantastic. Why you are telling me that 12 months treatment? Then I told that mother, look here, it's not a good news for you. That is when I recollect for using oral steroids, not as a substitute, but steroid responsive hyperactive airway disease.
That is a very important, I think, take-home message for, in the office practice, this is extremely useful. So it's a trial of oral steroids to convince the patient that steroid has worked and nothing else, right? And you'd probably be able to tell them that, look, one tablet of whatever prednisolone you gave is there in the whole inhaler. And this is how you could use it and tell them that this is a very low dose.
Scientifically, we are not recommending
that I agree.
A couple of tablets as a substitute for 12 weeks of therapy. But let that message be very clear.
But this is one of the practical ways of convincing a patient and your own self that you are dealing with a problem inflammatory rather than infective, right? I think that's very, very important.
Jayant wants to come.
Jayant, bolo.
But sometimes there is a flip side to it, Sometimes it may just happen so that the patients get an idea that this is a magic tablet and this is going to be curative. Probably it is going to be distracting them further and probably in discouraging them to use inhalers all the more. I think, we should give them like we say, when a child is admitted with an acute severe asthma, we always give them a written action plan. So similarly, we must be very explicit in our explanation and counseling about the right dose of steroid and where to use. We in fact should caution them that it is not to be used inadvertently. Otherwise, people.
That is exactly what I told. I told that I am recollecting one mother whom I tried this. That's why I told not all mothers.
Correct. So it should not be a take-home message. You should not.
No, this is not a take-home message at all. We are very clear. Now, Ranjan, I think let's come to cough suppressants. And when do you use cough suppressants? And there are two cough suppressants we know is dextromethorphan and levochloperazide. Can you enlighten us on these two cough suppressants? Which is safe, which is to be used at which age, how does it work? In short, in about say a minute or so, can you tell us? Dr. Ranjan, please.
Yeah. So usually cough suppressant, we have to see whether a dry cough or wet cough. In a wet cough, it is you cannot use this cough suppressant. Only in dry cough, if it's severe, sometimes a symptomatic purpose you can give, but you can not use in the early below. Dextromethorphan usually coming in combination. It is not coming as a single formulation, but levochloperazide is coming in a single formulation, usually combination also. But always cough suppressant should be given at least after 2 year phase. So it's not given in the early, in the first phase. We are not using this cough suppressants. As in market, always there is combination of the drugs are coming. We also doesn't know about the combination. Sometimes the cough suppressant as well as the expectorant are coming in the same preparation. So you have to use the single formulation if possible. And usually we are not using in the first life. We are giving after the second life.
Okay. Yes, Subbu, any inputs from your side, Subbu?
Yeah, only I can tell you two things. No cough suppressant should be used in younger children, infants, and at least in children below 6 years of age, where cough is very common. That is one. Number two is that we have a central and peripherally acting cough suppressants, which Dr. Jagdish has shown in the slide. I think the peripherally acting cough suppressant is really need of the hour, and pharma have not done anything in that regard because we are encouraging them with other cough syrups that we have got. So they're not really going into any research on cough suppressants, which is really need of the hour to suppress an unwanted cough. Because mother demands and nothing wrong. See, we give paracetamol when we know that the fever is self-limiting, but we relieve the fever. So she also wants, she understands self-limiting disease, and there is a demand for an ideal cough suppressant, but we don't have one in the market. If you ask me what is the ideal cough suppressant, it is general anesthesia, because only then, the cough reflex is suppressed. Otherwise, it is a wanted reflex, protective reflex. Only in stage 3 and 4 of anesthesia, cough reflex is suppressed. Not by drugs.
Okay. So you don't see
Can I
any...
just?
Yes, Jan.
Yeah, I think I agree with Subbu that there is no true cough suppressant, and it is really a sad thing that there is hardly any research happening. It's really, and in fact, in the earlier years, if Subbu will agree with me, 20 years back we at least had some cough suppressant in our armamentarium. Not that we used to use very often, but even the codeines and the suppressants, the opioids, they also went away. See, we were not suggesting that you should use them left, right, and center. But there was a certain group of those pertusite type of situations where these medicines at least had some role to play for a short period of time. Now it's really a concern what to give for these small babies as a suppressant. Dextromethorphan happens to be, as Dr. Ranjan said, is the best bet. It is relatively safe, but I think I would just use it only at night time if the child is having a disturbed sleep because of cough. About levocloperestin, there are trials only above 5 years of age. There are two advantages. One is that levocloperestin does not have any associated action on the cold. So it's a pure suppressant. Second thing, it does not have any effect on the CNS. So perhaps it is something which is not to cause any drowsiness. So in the course of time, when a child who is older, if you need to use something like a suppressant, you can think of using levocloperestin. Otherwise also, as Dr. Ranjan said, there are no true formulations available where you have plain dextromethorphan. But for an older child, say more than 8 years of age, sometimes if it is an irritating cough, it is worthwhile using lozenges of dextromethorphan, which can help you control the cough for a short period of time. Now you must be knowing that schools have become very jittery. If they find one child coughing, they will tell all the parents and tell the child to go home. Now, what happens is that if the cough is something like a post-viral cough or something like a past cold, then you need something to just loosen up or soother. So something which can just be a demulcent, can be a throat soother. You can think of using lozenges in an older child. So that can be one option where you can think as a cough suppressor. Thank you.
Now, I have got a couple of counter questions. Now, if the cough syrups were so bad, why they are so popular? And even why the practitioners also feel they are good? Let me answer this question, because this is very important for the office practice pediatricians. What is happening is most of these cough syrups will produce sedation, which mothers are very happy when they give the first couple of doses. Child is coughing, crying, very irritable, cranky. You give paracetamol and a spoon of cough syrup, they doze off and they are very happy. But the issue is that it abruptly changes the sleep cycle of the child. Child will sleep for first 4 hours and it will get up in the night and start coughing and disturbing the parents. Number 2 is it interferes with the feeding. Third is it interferes with the monitoring of the child, because sedation is not good, especially if a child from URT goes down in young age to bronchiolitis. There is no way that I can monitor, because moderate bronchiolitis can become severe bronchiolitis because of altered sensorium produced by the cough suppressant or by the tachycardia caused by the phenylephrine, because both of them are evidences of hypoxia. And that is why we don't want. It is not that I don't want phenylephrine or dextromethorphan or an antihistamine, but that because I cannot monitor a child from progression of an upper respiratory to lower respiratory, which can happen 1 in 10. And it directly affects the monitoring of the child, because the treatment of bronchiolitis is again symptomatic and therefore, and based on the severity. So I will not be able to assess the severity, and that's why we discourage them. And there is no evidence that they would help either. These are very, very important for one pediatrician to understand himself before he tells the others.
Yes. I think that's a very good take-home message. And if you at all use it, please remember it is not required, it is harmful, and use it with a lot of caution. Only when you want to suppress the symptom, be sure that you are taking a risk by doing that, right? Subbu, when do you use azithromycin, in your practice when the patient comes with cough? Because I find azithromycin used left and right by all pediatricians. Can you guide us on what are the real indications of azithromycin in a child who presents with cough in the OPD? When do you use it?
If you have sixth sense of knowing pertussis in the first week, because very sorry, Jayant would agree with me from ID as well. It really requires guts for a pediatrician to diagnose pertussis in the first week when the disease mimics any other disease. And it's only when it gets prolonged, we are helpless, but then we want to use azithromycin. So I would say, irrespective of immunization of status, but when you suspect pertussis. Number two, when you have this chlamydial coughs, or in older children and teenagers, when you have this atypical pneumonia with cough. But mind you, what one should understand is when you want to use azithromycin instead of amoxiclav. When an organism is not having cell wall, that is when amoxicillin doesn't help. Most of the organisms, respiratory organisms, do have cell wall, and therefore you can use penicillin group of drugs. And therefore, amoxicillin or amoxiclav would become drug of choice for most of the respiratory infections. It is when you have atypical infections that you need azithromycin in place. And in some cases, for example, if you seriously ask me, a penicillin allergy patient, or you have drug reactions to penicillin, either in acute otitis media, pharyngitis, or respiratory infections, I would use azithromycin. But for some reason, I find practitioners going for clarithromycin instead of azithromycin. But really, I do not have any kind of take why he should go for an expensive drug when a cheaper drug in India could work. But remember, it's one of the reserve drug for tuberculosis as well. And azithromycin, today you read Times of India or yesterday's Times of India, it has been mentioned that it is one of the most abused drug. So the reason why it became friendly was because cheap, once a day, and for 3 days, the pharma starts promoting it like anything. And that is why it has become very friendly for many pediatricians. And instead of 2 or 3 times a day for 5 to 10 days, they started using this. So my dear friends, there are no indications for azithromycin in day-to-day practice. If you are a strange practitioner who see 100 patients of benign bacterial infections, you may get 4 or 5 which are indications for azithromycin.
I think that's a good take-home message as far as the use of azithromycin is concerned. And Subbu, I think the question for you is now, all pediatricians use, inhalation therapy for all patients who come with cough. Now you tell me, what is the real role of nebulization? Is it required for all children who come with cough? And what is your take on using in the OPD nebulization versus meter dose inhaler and spacer?
Okay, so you really put me in fix. Jagdish, you could be answering because you are the busiest practitioner than me in a lighter vein. I think Biswal and Jayant also would agree with me because they are also practicing along with us. Maybe I will take the support of all of you in giving some clear messages. What is important in practice is that cough is more common than wheeze. And often the wheeze is not documented, especially when you have cough in bouts, when the cough is without fever, and you have a doubt whether it is a reversible airflow obstruction bar irritation, then I would use salbutamol or levosalbutamol, either as an inhalation by nebulization or as an MDI. With what device you give is not important, whether you want to give salbutamol. So the indications for salbutamol in practice is any cough with wheeze, any cough with probable wheeze, any cough which could have come with wheeze, but right now I am not having document of wheeze. I think Jagdish, you can also make out.
Yes.
I expect a wheeze now, but the child is otherwise fine. I don't know why, for some reason, when I auscultate, you don't get a wheeze, but this child could wheeze in the night. I think you have that fifth sense. You can make out those children whose cough which I showed are similar to asthma, but not associated with wheeze. I'll repeat again for the practitioner's sake. These kind of things, where when you auscultate, you don't get a wheeze, and a wheeze is part of the cough. These are the children whom I would use salbutamol or levosalbutamol. Either use salbutamol or levosalbutamol, both are same. There is absolutely no difference. Which is the device? In infants, you can use nebulization. In older children, you can use MDI with spacer. Now, the question is, if I use nebulization, will they become addicted? Answer is no, provided you educate them. Don't give prescription of home nebulization. Please tell them to come to your clinic, get nebulized and go back. And tell them that when you feel that I can't come twice daily to the clinic, that is when you really do not require either.
Correct. Yes, yes.
And can I give equivalents of oral levosalbutamol or salbutamol? Answer is yes.
Yes. So that's
and if they don't respond, don't go on continuing.
correct.
Isolated salbutamol or levosalbutamol is cheaper and better than a combination of salbutamol with other drugs.
That's right. That's right. So I think there was, how much time do we have now? Can you tell me, the organizers, and Akshita or Neha? How much time do we have now?
10 minutes.
10 minutes. So I think we go through a little bit of few cases, and then there are 4 simple questions we need to ask about the cough to arrive at a diagnosis. These are the few things that I wanted to share with all of you. How long is the cough has been there, how it started, when is it worse, and the nature of cough. These are the 4 questions I think all of us need to ask in the OPD, and it gives us a lot of information. Now, a sudden onset cough, always think of a foreign body. A few hours, in asthmatics, they become, within few hours they get that cough, and a few days is either croup, viral infections, bronchiolitis. When it is few weeks, you are probably dealing with asthma, TB, interstitial pneumonia, and months of chronic cough would probably mean it is asthma, cystic fibrosis, or habit cough. Now, this is a very beautiful slide.
Jagdish, one line from me.
Yes.
Especially about foreign body for the practitioners. When to suspect foreign body in clinical practice, office practice.
Yes.
If you have a child with cough whose symptoms wax and wane, when you give antibiotics, it gets better but comes back again. When you give bronchodilator, it gets better but comes back again, and doesn't become very serious. It goes like this.
Okay.
And that is when it is dynamic and maybe mobile. If you don't have localization, suppose you have localization, fantastic. If you don't have a localization, waxing, waning of symptoms is very, very important, because infections don't wax and wane.
Yes.
If there is a erratic behavior of symptoms, then it is always foreign body.
Yes. I think that's a very important message. And especially, very often these patients are put on inhalers thinking of a possibility of a, probable asthma, and the patient doesn't respond to inhalers at all. Plus, there is no family history. This is where I think I would also suspect a possibility of a foreign body. I think that's a very good input from you, Subbu. And this is a very important slide in which the onset, as when it started, also gives us a diagnosis. Any cough that starts in infancy, please think of congenital abnormalities. Viral infections are more common. In toddlers, when they start going to school, you get recurrent viral respiratory infections. In school age group, you probably get airway diseases where HRED probably comes into action. And adolescents, please remember TB, chronic suppurative lung diseases, take up the, are one of the commonest reasons why it comes up. Now, these are general, I would say general rules. They are not, watertight compartments. And where is the cough worse is also. Worse at night is asthma, all of us know. Cough associated with nasal symptom comes with the, post-nasal changes. That is when the child goes to sleep. Swallowing triggering cough is aspiration. When it occurs a few hours after, means please know GERD. And worst and early productive during the day is chronic suppurative lung disease. Now, please remember, habit cough is again a very common cause of cough in children nowadays, because what has happened is children have thought that their school has become an optional thing for them. And when they want to avoid school, they start getting a lot of cough. And I've seen a lot of patients of late, not wanting to go to school and coming to us with habit cough. I think this is what I would like to share with a lot of.
And Jagdish, they disappear in sleep, and they
Yes,
disappear.
yes, that's
That's the
right.
part.
Not coughing at all at night and coughing throughout the day. And, especially when they don't want to go to school is habit cough. I think the incidence has increased.
And in fact, infections are worse in the night than in the day.
Yes.
Whereas this is fine in the night, but worse in the day.
Yes. True. Now, basic, I think we have dealt with this. Dry cough is upper, whereas wet cough is, I think Subha has told us all about this. And cough is a predominant symptom of an airway disease. Afebrile episodes, recurrent, trigger-induced cough nocturnal, family history. Now, please remember, this is a very important cause of cough, which you need to understand and treat properly. And I think these are very important rules that we need to know. Now, this is a slide which I would like to share with all of you. See, important red flag signs is sudden onset cough that is not getting all right. And Subhi has also told us as to when to suspect a foreign body. Then progressive wet cough increasing for 3 weeks. Please remember, you need to investigate. Failure to thrive, I think Jayant has already told us. Hemoptysis is something that is alarming both to the pediatrician as well as all the parents. Cough initiated within the neonatal period. Remember, it has to be an organic cough. And it is a cough which are probably worried. And it is very important for us to diagnose, the PCDs, that is primary ciliary dyskinesias, or airway anomalies, even a child is initiated in the neon. And these children generally don't thrive well. Okay, swallowing difficulty, shortness of breath, chronic exertion. And what Subbu told us, the child is breathless, not much of cough, but he is faltering on the growth chart. And any acute life-threatening episode that comes with cough, I think we need to investigate and probably do a bronchoscopy. Okay. I think this is a slide. Acute cough, prolonged cough, chronic cough, recurrent cough. I think all of us know about this. And children are brought to us with cough for 3 weeks. They always come, doctor, देखो 3 महीने से वो खांसी रहा है, 3 हफ्ते से खांस रहा है. Now remember, you need to characterize this cough, and please remember the green line is the most common at present. And these are viral infections with a delayed recovery, which Subha has already told us. The blue line indicates a HRAD, which, there is recurrent variable cough. And the red line is persistent non-remittent cough, of which we are worried, particularly if it is tuberculosis or a foreign body or a pertussis. Okay. So please characterize this cough. So whenever you want to assess the cough, how long, when it started, when is it worse, and what's the nature of the cough is very important. Now, assessment of cough in a few case scenarios. This is sudden onset cough in an 18-month-old child with a hyperinflated left side is foreign body. This is a 2-year-old child who has just joined, is just going to preschool, nursery, gets repeated viral infections. He's otherwise okay. Is, viral associated V's. Then this is a 7-year-old child who has come with dry cough, loss of appetite, recurrent cough, allergic markers, erythematous turbinates, and all of you know that this is allergic rhinitis. And this is probably an asthmatic child who requires very good treatment. This is a 10-year-old boy who has come with cough for more than 4 months. Okay. And he is also not gaining weight. He has got clubbing. And you know that this is a child with chronic suppurative lung disease. He is an adolescent who has come with cough for more than 15-20 days. And this is a child who has got pulmonary tuberculosis. Now remember, in tuberculosis, isolated cough in the absence of fever. The word isolated cough in the absence of fever and weight loss is most unlikely to be TB. So always you should have some weight loss, or there should be some fever in patients with TB. Do not start anti-TB treatment empirically. I think all of us have been hammered by the IAPA and their tuberculosis module, and always arrive at a microbiological diagnosis before you diagnose TB and put the child on TB. I think this is a very important message I would like to give. And always in the management of cough, try to reach a diagnosis. It may not be always easy. Treat the cause. HRADs, inhalation, bacterial pneumonias, chronic suppurative lung disease, antibiotics. Now, these are management of cough. I think we've all gone through, and cough syrups do not really work. They're irrational, contradictory. So we are not going to use cough syrups at all. And if at all we use them, we use rationally only when necessary to suppress the cough. Cough syrups which have too many ingredients are definitely irrational, and failure to respond may take about 10 to 14 days to subside. Distressing cough is a nuisance, but not medically serious. Remember, do not change cough syrups. Use them as and when necessary. They really do not work. And a child who comes with cough, now significant cough is rare in newborns, but when it is present, it indicates a serious disease, which Jayant has already told us. Be aware of pertussis, we has already entitled. Avoid cough and cold syrups, can produce sedation, irritability, and hamper the monitoring of these children who come to us. Now, antibiotics are rarely required in a child who comes with cough, because the cough as a chief symptom is rarely due to a bacterial infection. And please do not use antibiotics as cough syrups. Okay. So the key points are how long, age when it started, when worse, and what's the nature of cough. With this, probably you will be able to come to a diagnosis, clinical diagnosis on the patients who come to us with cough. See, this is a beautiful chart wherein the history and physical examination tells us how to go about. I just go through that. Life-threatening, of course, requires immediate monitoring, foreign bodies and all such things, or pneumothorax. But non-life-threatening is what we see in the OPD. When it is specific or non-specific, you also get non-specific cough, which is non-life-threatening, and this is usually a cough variant asthma, psychogenic cough, that is habit, somatic cough, and a post-viral cough which takes a long time to subside. Specific cough is either infectious or non-infectious. Please take the temperature with the thermometer. When it is infectious, very often it is viral or bacterial. It may be URTI, rhinosinusitis, persistent bacterial bronchitis, or suppurative lung disease. Bacterial can be LRTI. Chronic cough, please think of TB, tuberculosis, and immunodeficiency. Non-infectious cause, when it is recurrent, think of asthma, aspiration, and a persistent cough may be a retained foreign body. And please remember, interstitial lung disease, not very common, but a rare cause of cough in which the child is more breathless or is activity limitation, mild cough, and the child is not faltering, and child is faltering on the growth chart. So this is a growth, this is a flow diagram which can probably help us in coming to the cause of cough. So thank you so much. And with this, I think, any questions from the audience? Any questions in the chat box?
Sir, there are a few questions in the chat box. I will just narrate those questions. Just go through that. Number one, Dr. Sushma has asked, does Montelukast help below 6 months and if used for 10 days or less? Already answered, but still you can answer it.
Montelukast is definitely not indicated below 6 months, and it will just not help. So Montelukast is a big no-no, and of course not in a child below 6 months of age.
Another question from Dr. Sushma again. What about use of polcodeine in cough control below 6 months? Is it safe? Parents
it is
want
extremely dangerous. It is contraindicated.
And will harass the doctor. Does ambroxol helps in small kids below 6 months?
See, this ambroxol, guaifenesin, bromhexin do not work, and full codeine. That codeine is a big no-no. Please don't do that. It is a central suppressant. And it's a very, very dangerous drug to use it. And please remember, if the parents go on the net, they will find that it is contraindicated. So please, madam, don't use that drug at all.
And sir, it is not available also. It is banned now.
Yes.
You don't get medicines like polcodeine, fencidil, linctus codeine. All those are banned now. Anything containing codeine is not available anymore.
On noscapine?
That is also not available, I think, now.
It's available, still available.
But I am not giving it at all. None of us are using it.
Yes.
I think Sushma is from Goa. It may be available there.
Dr. Sushma Kirtani.
Sir, coscopine is available.
Okay.
If I'm correct, the same Sushma who is asking the question, then it could be, but otherwise I do not know.
But cough syrups are a big no-no. Please don't use them. It's the basic cause of cough. Please remember.
Yes. Dr. Umar has a question. Can oral steroid be given for respiratory complaints in children less than 6 months? And when should we go for it?
Jayant, that was a question for you. Can you answer that question? Otherwise, I will.
I think generally you would not use an oral steroid unless you are dealing with a situation like a croup. A child who is coming to you with a lot of inspiratory difficulty, a child who has got a very short history, a little bit of fever, a little running nose, and sudden change of voice, and the child is having inspiratory difficulty. There probably you are justified in giving a dose of steroid, but there also perhaps the best option is to give a single dose intramuscular dexamethasone injection. That probably would be more beneficial with a nebulization than to give a course of oral steroid, provided you have controlled the croupy cough This is the only indication I would suggest for giving a medicine for steroid below 6 months.
Jayant, I just want to ask you a question. See, a child below 6 months of age and has got a pertussoid cough, and then, the parents get so much worried, it is something like an acute life-threatening episode and a pertussoid cough. Do you think steroid will work in this situation? They don't
If
want
at all
to get
steroid,
admitted. Yeah, they don't want to
yeah,
get
agreed.
admitted. Yes.
But if at all there is some role in the management of pertussis, there is some role about inhalational budesonide being given
Yes,
to these
yes.
children. But the point is that it is not confirmed. It is not not proved in a trial. But there are some trials being conducted that for a pertussoid cough, you can give a trial of an inhalational corticosteroids, and that perhaps sometimes gives some relief in terms of coughing episodes.
Because,
See,
Yeah,
we
another
should understand that
yes.
in these prolonged cough, there is no prolonged and persistent inflammation. It is irritation and denudation of epithelium, and the epithelium has to regenerate and recover. Till then, the subepithelial collagen, which is rich in cough receptors, is exposed. Even the blast of air that is going and coming will produce the cough. And therefore, the steroids don't work.
I think that was a very good clinico-pathological correlation, Subbu. Huh? Very good.
Because if you take the microanatomy of a pertussoid airway or a prolonged cough, there is no eosinophilic inflammation or chronic pre-existing inflammation prior to the illness, which could work when you give steroids. So therefore, it doesn't work. And if your inhalation corticosteroids work, beware that the child is in asymptomatic phase of chronic progressive inflammation of asthma.
Yes, that's a very good, answer, Subbu. Very good. Very nice. Any other question in the chat box?
Yes. Dr. Pratibha wants to ask again, for dry cough, what should be prescribed, sir?
Subbu, I think that question is for you.
For a dry cough, what should be prescribed? Okay. I have no, that's very genuine. If there is a dry cough and nothing else, I will suspect foreign body. It depends on the age. Dry cough and a newborn chlamydia. Dry cough and an old toddler, again, suspect foreign body. Start with the cough, illness, suspect foreign body. Coughs comes along the illness or in the later part of the illness is a recovery cough and don't do anything. And a dry but prolonged cough. Let us say dry cough more than 2 weeks. How will you manage? You don't give antibiotics. Don't give cough suppressants. Look at pertussis. Look at other infections like tuberculosis. Negative. Go ahead. Suppose if it is a dry cough persisting more than 4 weeks, I am giving you all answers for dry cough. If dry cough persists more than 4 weeks, please give a trial of inhalation corticosteroids, even if it is not asthma. Because it is said that after doing PFTs, after doing PFTs, you don't find anything. You can give trial of ICS. And if it responds well and good, if it doesn't respond, counsel the parents. That is the protocol from any Chang. And I have got it in my article of cough. Hemant Bhaiya, I will share that article with you. You can share it to everybody who is the recipients.
Yes. So now there is a flow.
I will give a small message. Dry cough, prolonged dry cough, give a trial of ICS. Prolonged wet cough, give a trial of antibiotics.
That is very good. Try dry prolonged cough, inhale corticosteroids trial. And wet cough, you give a 14 days course of amoxiclav.
So that you are beautifully answering the question. So there is a flow of questions coming. So let us go to rapid fire. What are the recommended antihistaminic, if at all, indicated less than 6 months? Dr. Niranjan is asking.
Antihistamines will help in a cough that is caused by the postnasal drip, and 33% of the action of antihistamine is related to anti-rhinorrhea. See, if it is rhinorrhea and congestion, antihistamines will help. If it is block, it will not help in a cold. So the rhinorrhea part of contributor of the cough will be help. But in URTI, the cough is because of airway damage and exposing the subepithelial cough receptors due to collagen. The postnasal drip causing cough. I think if I can tell somebody, let's say a child has a running nose, it sleeps off, there is pooling of secretion in the throat, and it will have cough clearing. that may be helped by antihistamine.
And the
Okay.
antihistamine below 6 months is chlorpheniramine.
No, not necessary.
You
That may
cannot
not
use.
work.
Yeah.
See, you need a really
No,
good
but
antihistamine, and that is and then the side effects outweigh the benefits. See, we don't say we don't use. When we use, the benefit that you are going to get is hardly any, but for the unwanted side effects. That's what the practitioner need to understand.
no, but
Yes.
they are asking which antihistamine. Because see, below 6 months, we don't use liver, this
We
thing,
don't use. If at all, you want to use antihistamine, let's say I will now for a while I will speak as an offender, or I would say culprit who wants to use an antihistamine. Please use first generation antihistamines. That is for
that is
infections.
chlorpheniramine, no?
No, chlorpheniramine or even promethazine and all that. But no, my point is, if at all you want to use, but second generation antihistamines for allergy, first generation for
I think you're, hello?
infections and second.
Hello. Yeah.
Yes. Yes.
Indicated, I'm telling you. But if you want to indulge this way, not the other way.
Okay.
Yes. Then Dr. Vishwanath is asking what dose of levocloperatine is recommended, 5 to 10 and over 10.
So there are no dosage.
I have not used.
Can I take it?
Yeah,
Yes,
please.
Yes.
Yeah. So I think there are no specific dosage recommendations, and there are no real listing. Levocloperazine is to be used only in older children. It is a non-sedative cough suppressant with minimal side effects. It does not contribute to congestion, like it does not cause drying of the airways. So there are some basic advantages. The mechanism through which it works at the respiratory epithelium side. So probably it is something which is a locally acting antitussive. Only thing is that in spite of the tall claims, it does not really seem to have that much of benefit. Now, for a child who is weighing 5, see, basically below 5 years, we don't recommend. So above 5 years up to 10 years, the recommended dose would be 5 ml. And you don't really get benefit by increasing the dose for an older child. As I mentioned you, for a child who is 10 or 15 years old, just giving 15 ml of levocloperazine doesn't work. So I think it is just a question of suppressing it for that particular time. It is just one of the alternatives available, not very researched thoroughly, not easily available, still requires some more references before it is used very commonly. Thank you.
If you ask me the question on antihistamine for the future, maybe today you record my words. What can come after 5 years, I'll tell you. Azilastine is a drug which is used along with intranasal steroids, which is a locally acting antihistamine. So therefore, in future, you may see azilastine nebulizations. Maybe you may get, and then, locally acting antihistamine, and there is no sedation. I do not know. I'm just guessing. These are the things that can come in.
But Dr. Subramanya, there is a caveat here. Azilastine cannot be recommended below 5 years of age.
No, all the drugs which are not recommended below will after usage will start becoming. Hemant and Jayant, I'm talking of 2030 and 35.
So Dr. Subbu sir, Dr. Sushma responded to you. His syrup Tedicoff LX is available in Goa.
No, what else is, I have got a question for her. What else is available in Goa, which is a cough suppressant,
So Dr. Shiva Gurunathan is asking dextromethorphan use less than 6 month usage.
No.
One liner.
Dextromethorphan not to be used.
Yes. Dr. Ujaswini is asking what about combination of promethazine folcodine?
No.
Not to be used. Not to be used.
I think she is referring to a
So I wanted to ask
called
I wanted to ask few of you, will you mix beer, wine and whiskey together?
Who is responding? Dr. Shrikant, in children, what is the incidence of GR with severe cough and vicious cycle of exaggerating the present cough?
For GER, cough syrups should not be used because salbutamol and oral drugs can actually relax the lower esophageal sphincter. Better not to use. If at all you use, you must use inhalation, either nebulization or MDI, but treat the reflux with PPI as a trial of therapy for 4 weeks, and if it responds, well and good. Otherwise, you reinvent your diagnosis.
Dr. Rajiv is asking, what about mucolytics?
Mucolytics only in chronic persistent airway diseases like cystic fibrosis, primary ciliary dyskinesia, post-tubercular bronchiectasis with thick secretions, where really thickness of secretion will prevent beating of the cilia of the respiratory tract.
And
Dr.
if I may add, Dr. Hemant, in
Yes.
such a case, mucolytics to be used by the nebulizer route,
Yes, inhalation.
inhalation route. In
yes.
those cystic fibrosis patients, there are special preparations available of mucolytics, which probably help you directly to make the viscid secretion a little thin. So it has application only in chronic suppurative lung disease.
Dr. Rakesh Gupta is asking role of honey in child with cough.
No.
Honey is better to indulge than other drugs, although
Yes.
I will tell you the way in which the evidences are there. No cough syrup, number 1. Number 2, no cough syrup. Number 3, no cough syrup. Number 49, no cough syrup. Number 98, no cough syrup. 99 is honey.
The last question, Anjana is asking, Dr. Anjana, is it all right to advise adrenaline nebulization at home, sir, in bronchitis?
No.
No,
No.
not at all.
Not at all.
There are important indications. Adrenaline is actually a medication of past now. It has some role sometimes in an acute croup-like situation. But remember, all those who have used adrenaline in their office practice will agree with me that after you give an adrenaline nebulization, there is a marked tachycardia, and more often than not, the child vomits. After that,
No,
probably you find the relief. These
yeah.
two are very risky situations, and adrenaline is a very dangerous drug, not to be left at the parent's responsibility to take. So I would strongly discourage use of adrenaline at home for any purpose.
I will tell you, adrenaline can be used in home only if either the father or the mother is a pediatrician.
Yeah, and that too only for anaphylaxis.
Yes, lastly, just this is rather question is a comment. Probably Dr. Subbu sir and all, Dr. Dekni sir, Dr. Jain Joshi can think of a webinar having a small case scenarios, invited case scenarios with the questions, rather than talking with so many questions came in the last moment of 5 minutes. So I think so we should have the questions answer.
Hemant
session.
Bhaiya, it is for Maha IAP. You are the president, and let there be session 2 on this because of the if somebody from the audience asks, it is tip of iceberg. Yes. I wish to have the same panel and have the questions from the audience, and what think we can do is we can ask them to raise hands, promote them as panelists, let them tell what they do in the office practice, and then they can get depromoted as delegates. They can come in and go and ask their questions also live. Hemant Bhaiya, take up that session. No, when delegates ask, it is our privilege, and we will learn from them. Now this is one way they are learning whatever that little that we could give. Even we need to learn from them. There could be something clicking at some places.
Yes. Yep. Anyone to say anything? Otherwise, Dr. Neha, please.
No, I have got one last liner. Jagdish Bhaiya, permit me.
Yes, of course.
If there is cough, don't worry. If there is no cough, worry. Number 1. That is because your protective reflexes are working. Number 2, if there is no cough but a disease, then it is never an asthma. You can't think of asthma without cough. You can think of asthma without wheeze, but not without cough. So therefore, my dear friends, if somebody has a wheeze but no cough, don't diagnose asthma. That means it could be a vascular obstruction, it could be a foreign body intraluminal obstruction due to lymph node, etc. Only wheeze or a stridor. without a cough. I think I'm making it very clear because that means your airway is not inflamed but only obstructed. Am I clear? So
Yes.
there is no irritation of airway. This is a very important message. That is how we miss mimics of asthma. So straight away you can diagnose asthma or no asthma, because asthma should have cough and wheeze, cough more than the wheeze. And in other cases, obstructions, you have wheeze more than the cough. Number two. Number two, again on the similar note, if there is no cough, then it is not asthma. If there is cough, then it is not TB. If there is cough, then it is not TB. And if there is no cough, then it is not asthma. This is within inverted commas. What I meant was, don't go to exceptions in general. If there is cough, then you have ruled out TB. If there is no cough, you have ruled out asthma. These are two common things that trouble us in practice, apart from day-to-day practice of respiratory infections.
Yes, any concluding
Well,
remarks on? Yeah, yes.
I don't agree with the latter part of Dr. Subramania's statement.
TB, because the RNTCP definition itself has a cough. I got your
so
point.
I think
that point
so I
is
think
mainly for the
that
adult
is
definition.
too. I would suggest that is too bold a statement to make. So perhaps I think we will take it with a little bit of pinch of salt. As the
You
earlier
can
part,
take
I
with
agree
pinch
with
of
him.
salt plus
You cannot
honey,
have.
Jayant. You can take with honey also. Not
Second
just
thing,
with salt.
as regards the first part, it is perfectly right that you cannot call someone asthma without cough. So it has to be wheeze plus cough. That is agreed. But TB is totally a different ball game. And in the years, all of us agree that TB has shown its so much of varieties and presentations that one can get foxed with tuberculosis at various ways. So I think that is too bold a statement, Subbu. I would not agree on
bold that. Means you can take more of cough, then it may not be TB. So it could be more an allergic variant.
I think that should not
I
be.
don't want to go on elaboration.
No, that should not be a take-home message. Please note. Thank you.
Yeah. No take-home messages. See, in cough and wheeze, which are the symptoms, we can't give take-home messages. We can give take-home messages for diseases, but not for symptoms. Always there are exceptions for symptoms. Because if there are no exceptions, then the science will not evolve at all.
I agree with you, but I think you can't be oversimplifying things. There are too many difficult things to handle. Okay. Thank you very much. Okay.
Yes, anyone
please don't mind us, Subbu. This is all in a friendly manner.
There is no mind. See, I will tell you what, it was pretty simple.
Otherwise the chairperson will get angry with vice chairperson.
No, it is not about angry. I agree with you. The point which I was trying to tell you was, if a child has only cough, then it cannot be TB. It should have fever, cough, loss of weight, etc.
Yeah, but so still only like cough, that, then it will make different. Okay. Chalo. Thank you, sir.
Yes.
I think it was a wonderful session. Overall, I think it was a great session, and I enjoyed the the participation of the audience as well as the panelists. And thank you, Jayan. Thank you, Subbu. Thank you, Ranjan and Hemant, Neha, and everybody.
Dr. Jagdish sir, we have Dr. Nilima to give the vote of thanks.
Yeah.
I think it's like around a year we get patients coughing coming to our OPD. So questions and discussion about the cough will go on like this. It's unending. And every time we get to learn new things from all these experts. Thank you, DIAP, CIAP, Dr. Basavaraj sir for joining and blessing the occasion. MAHA-IP President, Dr. Hemant Gangolia, Dr. Amol Pawar, Secretary. All these people are behind each and every program. They are standing there and making it possible. Today's panel and experts and moderator, Dr. Jagdish Dekhne sir, everyone was wonderful. It was very enlightening discussion and we enjoyed it also. They kept it on a lighter note also in between. So we kept on enjoying and learning both the things. So Dr. Jagdish sir, thank you very much. Dr. Biswal sir, Dr. Subramaniam sir and Jayan Joshi sir. All of you made this program wonderful. Thank you, all of you.
Thank you.
Thank you so much. Thank you, everybody.
Thank you. Good night. And thank you, DIP, for giving the opportunity. It was very nice. Thanks a lot. Thank you, Amol. And thank you, Hemant sir. Thanks a lot. Hi, Basav.
Yeah, thank you, James sir. Thank you.
Thank you, Basavaraj, for
Hemant sir. Thank you, Dekhne sir. Thank you, Nilima madam. Thank you.
Thank you.
Yes.
Thank you and good night. Bye.
Neha madam. Thank you.
Bye.
Good night.
Good night.
मजा आली. तू बघितलं की नाही?